next session, which is in neoadjuvant immunotherapy. I would like to invite Chairperson Dr. N.K. Warrior Sir, Medical Director and a Senior Consultant Medical Oncologist, MBR Cancer Center, Calicut. And speaker for the first session, the first abstract, is Dr. Boman Dhabar Sir, Consultant Medical Oncologist, Fortis Hospital, Mumbai. Over to Dr. Boman Dhabar Sir.
I'm thankful to the organizers for inviting me today to speak on this topic, which is a very new topic and hopefully should become a standard of care soon. So first slide, please. Let's see if I can share the screen. Okay, so better go okay. You all can go into the slide. Yeah. So today what I'm going to talk to you all is the role of immunochemotherapy, that is nivolumab with platinum doublet versus chemo alone when given in a neoadjuvant setup, that is those patients who have a resectable non-small cell lung cancer, and what are their surgical outcomes. Next slide. So just to introduce this topic, and as we were discussing so much about neoadjuvant chemotherapy, the facts are this big meta-analysis. What did it show? That neoadjuvant chemotherapy, when giving chemotherapy prior to surgery, that is chemotherapy plus surgery versus surgery, the 5-year survival rate was better by a meager 5% only. And there was no survival benefit if adjuvant chemotherapy was also administered. So neoadjuvant chemotherapy has a role, but the role is so marginal. So now coming to immunotherapy, what is the basic concept of giving immunotherapy in a neoadjuvant setup? We all know antigen presenting cells are the one which take the tumor load and present to the host T cells. And hence, it is believed that when the tumor load is large, that is when we give neoadjuvant immunotherapy, there is a large antigen load that the APC would give to the T cells. And hence, this is the antigen presenting cells, and hence it would elicit a stronger anti-tumor T cell response. That is the basic preclinical approach. And that is why, next slide. And that is why there are many phase 2 studies where you all can see single agent nivolumab, pembrolizumab, atezolizumab could give us a major pathological response of approximately, you can say it's from 20 to 45%, depending on what immunotherapeutic agents we use. The result looked most promising in phase 2 studies with nivolumab. And when immunotherapy was given along with chemotherapy, sorry, this is major pathological response only, there were the major pathological response jumped from 50 to 80%, depending on which immunotherapy agent we were using. And we all know, next slide, that we all use most of the time neoadjuvant chemotherapy starting from stage 1B to 3A. Next slide. So Checkmate 816 was also a study where they had used neoadjuvant nivolumab plus platinum chemotherapy for a resectable stage 1B to stage 3A non-small cell lung cancer. Next slide. And what they did was exactly this, that the patients who had stage 1B, more than 4 centimeters, to stage 3A without any sensitizing EGFR alteration, they 1:1 randomization between nivolumab plus chemotherapy or chemotherapy. The chemotherapy was the standard chemotherapy with cisplatinum, and depending on what the histopathology was, if it was a non-squamous cell, it was pemetrexed, and for squamous cell, they had used different regimens like docetaxel, gemcitabine, paclitaxel, and it was a direct 1:1 randomization, and it was stratified as per stage 1B, 2 versus 3A. PDL1 status less than 1 or more than 1 and the sex. And after completing 3 cycles of chemotherapy, there was a radiological restaging and surgery was done within 6 weeks post-treatment. And to give adjuvant chemotherapy was as per the standard of care. The primary endpoint was pathological complete response, that is by the blinded independent pathological review committee, and the event-free survival. The secondary endpoints were overall survival, and as I told you, major pathological response by blinded independent pathological review. And the key exploratory endpoints were overall response rate, feasibility of the surgery, and so on, so far and so on. Next slide. So as I told you, primary and secondary endpoints were by pathological assessment, and they were by the blinded independent pathological review, and they used the immune-related pathological response criteria, that is classically what is called as major pathological response. Major pathological response was the primary secondary endpoint, And what do we define by major pathological response is less than 10% of the residual viable tumor cells in the primary lung tumor and sampled lymph nodes. And pathological complete response, as we all know, is 0% residual viable tumor cells. And the second, and their exploratory endpoints when they did a biomarker assessment was tumor mutation burden on circulating tumor DNA. Next slide. So coming to baseline characteristics, they were very well balanced between both the arms. Slightly higher, we can see here, squamous cell carcinoma in the chemotherapy and slightly higher non-squamous cell in the nivolumab plus chemotherapy. And here, slightly more PD-L1 more than 50 were in fact in the chemotherapy arm and slightly lesser in the nivolumab plus chemotherapy arm in the neoadjuvant setup. Next slide. Now coming to the primary endpoint, that is a pathological complete response. As you all can see, when nivolumab plus chemotherapy was used, there was 24% pathological complete response compared to chemotherapy, which was just 2.2%, a staggering difference of 21%. And major pathological response also, as you can see, was approximately 37% versus 9% only when chemotherapy was used. So this initial report from the checkpoint 816 showed that there was significant improvement in the pathological complete response, and there was a major pathological response also. And of course, tolerability, safety, I'll show you in my subsequent slides. Next slide. Here, if you see the minimal residual viable tumor that was left in stage 1B2 was 28% only when nivolumab plus chemotherapy was used in the neoadjuvant setup, whereas with chemotherapy, the residual disease was 79%. And in stage 3A, as I told you, randomization was between stage 1B2 versus 3A. And if you see the minimal residual disease that was there in stage 3A when nivolumab plus chemotherapy was used in the neoadjuvant setup was just 8% compared to 70% in patients who had received chemotherapy without immunotherapy. Next slide. So this is just some of the results, and what we can see here, that patient completing 3 cycles of chemotherapy were in fact more when nivolumab plus chemotherapy arm. As you all can see, it was approximately 94% compared to chemotherapy. In fact, more patients completed the 3 cycles, and pneumonectomy, but of course, these are very small numbers for 17 versus 25. So much few patients underwent pneumonectomy when nivolumab plus chemotherapy was used. Next slide. So if we come to the pathological complete response, which was the primary endpoint, and here in the intent to treat population, that is in some patients in whom radiological progression was seen or there was radiological no response and they underwent surgery. In fact, still what we see here, that the pathological complete response was 24 compared to 2.2, as was the same, whereas those who actually underwent surgery, it was still higher, 30.5 versus 3.2%, and the tumor, if you see the primary tumor only, it was 25.7 versus 2.2. So whatever you see, nivolumab plus chemotherapy did better as regards the pathological complete response was there, even if there was no radiological benefit seen. Next slide. If we see the subgroup analysis here, what we can see, that it be stage 1B or stage 3A, whatever, this nivolumab plus chemotherapy was better. And here also, whatever the PD-L1 expression, even with those who have PD-L1 expression less than 1, the benefit was there. However, with more than 50%, of course, the benefit was much more. And one more thing I want you all to see is, we always think that in neoadjuvant chemotherapy, we want to use cisplatinum as far as possible. But when nivolumab was used, in fact, carboplatinum was marginally better. I would not say marginally, but they were nearly same, I would say, because the numbers are very small. Next slide. So in the neoadjuvant setup, carboplatinum was also used. Now, if we see the overall response rate also, the nivolumab plus chemotherapy did better, 54% versus 37%, and radiological downstaging was also better when nivolumab plus chemotherapy was used. Next slide. And from the toxicity, when we think that we are adding nivolumab plus chemotherapy, we would think of more grade 3 and 4 toxicity, but somehow in this paper, if you all can see here, the chemotherapy arm grade 3 and 4 toxicity were more than nivolumab plus chemotherapy. The explanation I do not have really. Next slide. Next slide. And that is why right now there are multiple studies going on which I could go through the literature, and they were with single agent, nivolumab plus of course chemotherapy. Now all the studies which are phase 3 going on, because this was the first phase 3 study which is presented. So nivolumab plus chemotherapy or nivolumab with different immunotherapeutic agents with chemotherapy, standard chemotherapy was given. Some of them used 4 cycles, and there are many studies where adjuvant also immunotherapy being continued. So let us see whether we can improve really the overall survival for our patients when we use immunotherapy plus chemotherapy followed by adjuvant immunotherapy also. Next slide. So to summarize, CheckMate 816 met its primary endpoint of pathological complete response with addition of nivolumab to neoadjuvant chemotherapy for newly diagnosed resectable lung cancer patients, those who are stage 1B to 3A. Pathological complete response benefit was consistent across all subgroups. Major pathological response and overall response rates also improved. For event-free survival, which was a co-primary endpoint, the data is still immature, and I'm sure we'll be seeing that in a few years. Subgroup analysis, of course, which was not clearly mentioned, but it was shown that circulating tumor DNA clearance was more frequent when nivolumab plus chemotherapy was given versus chemotherapy. They did before starting and after 3 cycles circulating tumor DNA. And the circulating tumor DNA clearance was much better when this combination was used. So neoadjuvant nivolumab plus chemotherapy demonstrated a tolerable safety profile. As I showed you, day 3 and 4 toxicities were not really high, in fact were much less, without adversely affecting the feasibility of surgery. So this was the first phase 3 randomized study demonstrating the benefit of neoadjuvant nivolumab plus chemotherapy for resectable non-small cell lung cancer. And thank you for your patient hearing.
Yeah. Yeah. Thank you very much, Dr. Dhabar, sir.